Hi everyone, today I'm here with Dr. Humphrey, a cardiothoracic surgeon and thoracic surgery specialist in the Northern California, Sacramento area. So Dr. Humphrey, thank you for being a part of this interview.
Absolutely. Yeah, thanks for having me.
And before we go into the fine details of cardiothoracic surgery and thoracic surgery subspecialty, could you kind of give us an overview of what each of those specialties and subspecialties are, maybe the other subspecialties of cardiothoracic surgery as well?
Yeah, absolutely. So most of us start out as general surgeons, and so you train and go through residency as general surgery, and then you do a fellowship in cardiothoracic surgery. And that does include both, so we're trained as heart surgeons as well as general thoracic surgeons. So anything that requires the cardiopulmonary bypass, for the cardiac side, and then the thoracic is more lung cancer, esophageal cancer, chest wall reconstructions, and anything in the mediastinum. Most of us choose one or the other once we're done with training, either cardiac surgery or thoracic, i.e. everything else. But certainly there's physicians in rural communities that do both.
And what are the most common cases in maybe each of those subspecialties?
Yeah, so we'll start with heart surgery first. So in the cardiac realm, it's mainly, cardiac bypass and then also valve surgeries. But it gets a lot more in-depth into that. They remove tumors, they do operations for dysrhythmia, pulmonary embolism, so it's pretty broad as well. But their bread and butter is the CABG and replacement of valves. Mm-hmm. For the general thoracic, probably roughly 40 to 50% of my practice is lung cancer, so I do a lot of lobectomies. Then the rest of it makes up, I am a little bit unique in the fact that I do a lot of foregut surgery, so I do a lot of, Nissens and hiatal hernias, esophageal cancer, and then also probably about 5 or 10% of my practice is chest wall reconstruction, so people who have sarcomas of the chest, and then, large resections, and then reconstruct the thorax.
So there's a little bit kind of overlap into maybe like a general surgeon?
Yeah, so the thoracic surgery track is more in parallel with a general surgeon versus cardiac is kind of its own beast in a lot of ways.
Why in particular do you choose cardiothoracic surgery and thoracic surgery as kind of like your focus? Yeah,
so for me, and we all have our interests, right, in terms of, broad sweeping strokes, do you like surgery, do you like, medicine, or somewhere in between? Certainly, for me, I knew I wanted to be a surgeon. I just like to work with my hands. I'm competitive. I like to use my skill and talents versus the disease and try and come out on top. In terms of cardiothoracic surgery, just to me, the chest has always been the fascinating, part of the body. As a medical student, I rotated on cardiac surgery as an elective, and one of the coolest things I ever saw was a beating heart and being able to look at the EKG tracing and watch the heartbeat in front of me and see what it's actually doing on that EKG tracing. And then the complexity, right? So the cardiothoracic surgery, both sides of it are there's a lot at stake, let's say, right? The entire blood volume goes through, obviously, the heart, but it also goes through the lungs, and those vessels are very fragile. So I like having that high-end surgery and that high acuity and being there for the patient at their most critical time.
Okay, and could you walk us through a typical day in your life from when you come in to when you leave, and if that changes throughout the week?
Again, I'm a general thoracic surgeon. I don't do any cardiac surgery anymore. So my general work day probably, starts, I get at the hospital usually about 6:30 to 7. Round on my patients that I have in the hospital and get my notes set up if I'm in clinic, or certainly review all the images and, my game plan for surgery if I'm in the operating room that day. And then I generally am done, it varies a little bit because like anything in medicine, certainly you can get a consult or, have something pop up in the afternoon or evening that you were unaware of when the day started, but probably finish average about 6 o'clock. So I probably do 11, 12-hour days. I have one other partner, so my work week consists of being on call for a week straight and then a week not on call. So I spend half my life on call. Nice part about general thoracic surgery is it's mainly an elective practice. There's a few urgent cases, if you will, esophageal perforations, empyemas, those sorts of things, but the vast majority of what I do is scheduled. So I'm not up in the middle of the night very often. I'm not here in the middle of the night very often.
Okay, and so those calls, when you're on call, what's the schedule like? Is that, you have to be there for like 24 hours, or how is that?
No, it's home call, if you will, so I just have to be available and within 30 minutes response time for the hospital. So say a routine Saturday I'll get here a little bit later, maybe like 8 o'clock, spend some time with my kids in the morning. And then I get here around on my patients and my partner's patients. We cover 2 hospitals, so I cover here in Roseville and then also in Sacramento. And go see all those patients, write some notes. I usually will catch up on some extracurricular work that, is kind of stacked up through the actual Monday through Friday work week. And then I'm home, kind of early to mid-afternoon and spend the rest of the day with my family, just being available by phone if something comes in. But the vast majority of the time, that's, I spend 4 hours or so in the hospital each day on the weekend, and then the rest of the day is mine.
Okay, and how is that the lifestyle of a thoracic surgeon different from that of maybe other specialties? Would you say it's a lot more like time intense, I would assume?
Certainly, surgery in general tends to be more time intense, right? The medicine physicians, for instance, they'll work for a week and then they get a week off. That's not the way that it works for a subspecialist surgeon. There's just too few of you. So one or both of us are always available, 24/7. So it certainly is a little bit of a lifestyle hit, if you will, in that respect. But that said, thoracic surgeon tends to be a lot more elective than the majority of other specialties. So certainly general surgery, right, the vast majority is not. Trauma surgery, certainly not. Urology and ENT, it tends to be more similar or analogous to their kind of practice, where, they have a few urgent, emergent things, but the vast majority of what they do is elective.
Mm-hmm. Are you able to do like non-clinical work, like research or let's say mentoring or academic work or anything else, or are other surgeons able to? And if so, what would you recommend they do to get those opportunities? If let's say you just graduated residency and fellowship and you're a new doctor.
Yeah, so certainly those opportunities are available, and yes, I do take advantage of them. In terms of the research realm, so I started this job about 14 months ago. So I haven't done a lot of research here with Sutter, but I did a couple years in the lab while I was in training, and certainly plan to continue to do so. And I work very actively with our group here for education for the high school students here in vaping. I'm on our tumor boards, and so work closely to make sure we keep our accreditation. I do a lot of robotic surgery. That's the other piece that I think general thoracic surgery affords, as it's much more technologically advanced, despite what people think of cardiopulmonary bypass, but it's been there a long time, and so certainly a lot of advances on the general thoracic side, and so I'm one of the co-directors for the robotics program. So there's a lot of extracurricular things that you can do for sure. In terms of mentoring and those kinds of things, in private practice it's harder just because there's not as many formal medical students and pre-med students running around, but certainly there are some, and something that I like to do. Another opportunity that private practice does afford is after you're done training, I'm working out with the university here close by to have some of the general surgery residents rotate with me to get the thoracic experience. And I could be on 10 more committees if I want to. So there's lots of opportunity to do so even in the private practice world.
What are the most challenging and rewarding aspects of cardiothoracic surgery in general, but especially, I guess, your specialty of thoracic surgery?
Surgery in general, one of the most rewarding pieces, at least for me, and one of the hardest pieces is, again, it's your skills versus the disease. It's very different than medicine physician, which, it's more of the complexity in diagnosis, and then the treatment oftentimes is either medication or an intervention by somebody else. With surgery, you literally show up that day, not knowing what's going to happen in the next 6 hours, but just knowing that it's your hands that are going to either harm or cure this patient. And so it's a stressful situation to be in. There's a lot of sleepless nights for big cases in preparation and having your A, B, C, and D. But at the same time, that's the most rewarding piece. I told you at the beginning, that's the reason why I did this job. Right? I love the fact of having complex surgery, having it on the line, and having my hands versus the disease. So it's certainly a love-hate relationship with that respect, but far more love than hate. I love what I do.
So are there certain personality types that are, would you say, best suited for becoming cardiothoracic or a thoracic surgeon?
Yes, in the sense that you have to have a little bit of a hard shell to get through training. It's definitely a very on the more intense side of surgical training, even for that matter. And so, for instance, I did 7 years of general surgery because of the 2 years of research. Cardiothoracic surgery is a very competitive specialty now. and getting more and more every year, and then 2 years of CT training. And during those times, particularly the CT training, it was 120-hour work week. So something that you have to have, you have to be willing to put a lot of your life on hold for that time. But then the end result is very rewarding and worth it. In terms of personality types, I don't think so. I don't think that I'm necessarily the stereotypical cardiothoracic surgeon. And I at least pride myself on being very approachable and kind and just excited to be at work and work with others. And I think there's a lot of times that you get that kind of wall or barrier put up with a lot of surgeons and a little bit gruff. And so I don't think that there has to be a specific stereotype. I would just pick what you love, and knowing full well that you got to do it for a lifetime, and making sure that you actually are willing to make the sacrifices when needed, and then the outcome, which is the majority of your career, is well worth it.
Mm-hmm. Okay, and so for medical students interested in becoming a cardiothoracic surgeon, what tips would you give them to match into a competitive residency and then fellowship? Because you mentioned like the general surgery and then the CTE route, and I heard there's also like ones that we go direct.
There is, yeah. So there is now CT residency, like an ENT or urology residency. Those are very, very competitive as well. So really, all you medical students know how to, what to do, right? You have to score well on your USMLEs. You have to, rank high in your class and coursework and your hospital work in terms of to be able to match in a competitive residency. Because the reality is the first kind of hack and slash of applicants happens at the grade level. So if you don't make that first cut, it doesn't matter if you're the coolest person or the most skilled hands they'll ever see. They won't ever meet you. So you just have to be vigilant with your coursework. Now that said, if you don't make it into a CT residency, again, there's the fellowship opportunity, then that opens up a little bit more wiggle room in terms of your academics, right? Then you take, it's called the ABSITE for general surgery, which is, your basically an annual exam that you are scored against every other general surgery resident of your respective year, and you're put in a percentile. So you have time to show that, you're serious about what you're doing and making improvements on the academic side, and then being able to do research, and that certainly matters. And then just gives you more time to meet other people in the respective field and who you know in a small field like CT surgery. They only graduate about 90 of us a year, so it's a lot of who you know at that respect too.
Mm-hmm. Okay, and moving on to the employment aspect, since this is like a private practice technically, I think it seems like you can work in private practice, and then are there opportunities to work in like academics or do like locums work or things like that? What kind of opportunities are available in terms of employment for CT surgeons? Yeah,
so it's kind of gone in ebbs and flows over the last probably 20 years. Right now, very much so, there's a lot of job opportunities. So I get locums calls every single month asking me to go do locum somewhere else for either cardiac or thoracic surgery. And then academics and private practice, there's a plethora of jobs with that too. The only piece with it is, again, you're a subspecialist, right? Again, there's only about 100 of us a year that are graduated. So you don't need a lot of thoracic surgeons in every community. And so although there's a lot of jobs out there, if you want to be in this exact city at this exact time, sometimes that could be difficult because you might only need, in a major city, you might only need half a dozen CT surgeons total. So it just matters of if that job opens up at that time. But there's lots of jobs right now. I did not have a problem finding a job.
Mm-hmm. So how well are CT surgeons generally compensated? I'm sure it's going to be on the upper end of doctor specialties since you're in training for so long even, and it's so competitive to get into. Would you say that they're fairly compensated, and what tips would you give for CT surgeons to increase their income?
Yeah, so we are pretty well compensated for what we do. Like you said, it's a lot of years of training, plus the way that you're rewarded, if you will, by your RVUs, which is how we're all scored based on how you get paid. They take the amount of years it takes to do that, but also the complexity and risk of those procedures. So again, when you're dealing with the major blood vessels of the body every day, they pay you better than those that are not. So CT surgery falls in the first, depends on kind of what source you read, but in the top 2 or 3 most highly paid specialists in medicine. And so we're compensated well, both private practice and academics. In terms of how do you increase that, it's really comes down to it, outside of academics, right? Oftentimes that's salaried, and then you have to work that out based on your reputation and experience as you gain that. But in private practice, it's how hard are you willing to work? How many hours are you willing to spend? How many hands are you willing to shake with the primary care docs and the specialists, to send you referrals? And then you're compensated directly based on that. Most of us nowadays, when you start in private practice, start the first year or 2 years as a salary, so that way you have the time to build that up. And then after that, it's really the amount of work that you do. You get paid directly for the plethora of work, or if you do less, you get paid less.
Mm-hmm. And with all the advances in such a complex specialty and subspecialty, how do you stay on top of all those medical advances?
Yeah, so there's a lot of different ways to do that. The easiest is we have our societies. So you become part of the society, you go to the annual meetings and stay up on what's the current kind of research and literature that way. And then also when you're part of those societies, oftentimes they give you journals based in that respective field. And they're pretty easy to read, and you just kind of peruse on the ones that are applicable to you. Like for CT, obviously there's generally half that are cardiac, half that's thoracic, and you just kind of sort through what interests you and what your practice looks like. Then the reality is you never stop learning, right? Almost every single day that I'm in clinic and I see new patients, I learn something about those patients and I have to go look it up. So, I'll look up the current literature on, what they're doing and how they're grading, for instance, different, types of esophageal motility disorders. That's a changing paradigm. And so you just kind of read the most up-to-date current literature on that on your own. You learn those skills on how to do that in med school and residency.
And how do you avoid burnout?
I'm fortunate in the fact that actually cardiac surgery is one of the least likely burnout specialties in all of medicine, both surgery and just non-surgical specialties. And I think there's a lot that plays into that we can get into, but big picture is, not to sound arrogant, but you kind of sit on the top of the pyramid, and so oftentimes things that burn people out is, the whole feel like you're getting dumped on, or no one knows what to do with this patient, even though you're not going to operate. And surgeons, that's what we like to do, is operate. So you don't have to sift through the weeds very much. Oftentimes, you're able to look at imaging and sort out what you need to do with those patients. And then it's very rewarding in the fact that, again, I show up, in the morning, and then by the afternoon, hopefully I cured a few people of cancer, right? So the patient population tends to be very, very grateful, and it's very rewarding in that respect. And then burnout, it's nice in the fact that private practice, I can choose how little or how much I want to work based on what my life looks like at that time. I got 2 young kids, but I'm early in my career, so I want to learn how to do this job well, and so I work a lot trying to build that skill set. And then 5 years from now, if I decide that I want to kind of cut back a little bit, there's nothing that says that I can't.
Besides being in private practice and having that flexibility of changing your schedule, are there any other tips that you recommend for establishing that work-life balance?
Basically, don't give up the things that you enjoy. You know who you are. I think a lot of us try and fit into the stereotypical whatever specialty you're doing and forget about who we are as an individual. Right? We decide we're going to change how we're going to study because that's what the senior resident told me, that he used this book. I'm going to do something different. Right? Just ground in who you are. So that goes from studying techniques all the way to your extracurricular activities. Don't give them up. Yes, you have less time for them, but optimize the time you do have, and just have a nice balance with respect to what you're willing to do. I feel like I have a family. People with families, oftentimes that means I sacrifice a little bit more of the quote-unquote me time, and it's more family time and work time. But that's okay. That's a nice balance. The hanging out with the family is a reprieve and kind of a recharge the batteries.
Switching topics, do you have anything that you're excited about, or any technologies or advances in medicine that you foresee in the next few decades?
Yeah.
In CT surgery or medicine in general?
Yeah, that's a good question. And yes is the answer. Like I kind of alluded to, I do robotic surgery for my patients. I think that technology is getting better and better. We've had a couple different iterations of the robotic technology, and each time it's been light years more user-friendly and I think safer for the patient. And I definitely see that technology continuing, right? Robotics and integration of that is going to be the future. I know that they've already got prototypes and it'll probably be put into practice in not too long, where they can integrate on the screen that you look into. They can integrate either the PET scan or CT scan, in real time, so you'll be able to, utilize the 3D imagery with the anatomy that you're seeing there for patient safety and ease for the surgeon, quite frankly. And then changes in treatment of cancer is changing all the time. Lung cancer is certainly, on the forefront of a lot of that with immunotherapies, and there's new therapies coming out almost every month. And so I definitely see that continuing to expand and get better and better. And then the last piece is diagnostics for cancer. So the holy grail and what they've actually looked at since the 60s is trying to see if we can find circulating tumor DNA to diagnose patients. So you get a blood draw, and then we can screen you for 20 different cancers just with that blood draw. And there's actually Sutter, we're starting to do a study on some of those products with our patients now. So I definitely see in the next probably 10 years that something like that will exist.
That's pretty cool. I know it's still pretty early in your career, but would you choose the same career path again, or is there anything you'd change about it, maybe a different specialty or something like that?
No, I never once have and I can literally say not a day that I've looked back that I would change what I do. Even in the hardest of days and the least amount of sleep, I love CT surgery, and I think it's the perfect fit for me. For all the reasons that we said with the complexity. I also like the breadth of it, right? I can do a little bit of cancer here, I can do a little bit of foregut stuff here, chest wall here, some big cases that are stressful, some nice simple cases, and it has a really nice breadth of work. I certainly would not change a thing of the path that I've chosen, all the way from doing general surgery and spending 7 years in general surgery before becoming a general thoracic surgeon. I think all of those maneuvers for me were the right moves.
Mm-hmm. So last question, what tips would you give us to become good doctors?
Yeah, that's another good question, and you sent that ahead of time, and so I had a little bit of time to chew on it. And I think really what makes a good doctor isn't how smart you are, it's how hard you are willing to work. What is safe for the patient, and what really makes that difference is how detail-oriented are you? Are you going to go back and use that just a little bit more brain power to look back at their past medical history one more time? When you get that call at 2 o'clock in the morning and 90% chance things are fine, but there's still that little chance that maybe that patient really needs to be seen by a doc and needs your help, are you just going to say, yeah, it's fine, 90%, I'm okay, and roll over and go to bed, or are you going to be the one that gets up at 2 in the morning, drives to the hospital, and looks? And those are the life-changing courses for those patients. And if you do those things, I think that you become a very good, safe physician. If you don't do those things, you will get burned, which means your patients suffer. And then I really think it's important to be personable, right? These patients are coming in. I know to us we think a lot, it's the gallbladder, it's the lung cancer, and we talk about that a lot. And I think there's a good reason, and having a little bit of separation is healthy. But at the same time, they're coming here as a human, just wanting help and looking to you to, just talk with them, and look them in the eye and listen to what they say and, acknowledge their fear. And so being just a good person in that way and being detail-oriented and hardworking is, I think, the key.
So ultimately, I guess for both of those, being or valuing each person as you would want to be valued.
Yeah, as you would want to be valued, or, the whole stereotype, treat them just like they would if it was your wife or, husband or mom. And I think that holds true. And I certainly think of that every single day, not only on the recommendations I'm providing these patients, right? I mean, just because you can do something doesn't mean you should do something. Yeah. And so, just taking that step back and going, okay, is this what I would want for me? Is this what I would want for my mom? Now everyone's different, and so you got to treat the individual, but just having that kind of as your basis and your platform, I think is a good, healthy way to be a doc.
Mm-hmm. Great reminder. So thank you again, Dr. Humphreys, for being part of this interview. Thank you guys so much for watching. If you have any questions, feel free to write them down below in the comment section, and I'll ask Dr. Humphreys and get back to you guys. Thank you again so much for watching, and have a great rest of your day. Take care.